Good morning, everyone. Welcome again to Palliative Care Grand Rounds. Our presenter this morning is going to be Phil Ramos, and Phil's from Corpus Christi, Texas. He attended the University of Texas at Austin and received a bachelor's degree in biochemistry. And I apologize, I'm out of breath. I ran in from my car to get here. So I'll just put that out front. Phil earned his medical degree in 2000 from Baylor in Houston, Texas, and he stayed on at Baylor for his internal medicine residency, followed by a chief year. He finally left Texas to complete his nephrology fellowship at Vanderbilt. Phil moved to Denver, Colorado in 2009 to enter nephrology practice and was medical director at DaVita Outpatient Dialysis. After 10 years of nephrology practice, he decided to transition to a new career in palliative care and hospice medicine. Prior to starting his second fellowship, he briefly served as a hospice medical director with the Denver Hospice. Welcome, Phil.
Good morning, everybody. My name is Phil Ramos, also known as Dr. Phil. I am so happy to be here today presenting Grand Rounds to my friends and colleagues. It's truly an honor, so thank you so much. I first want to start off by saying that 3 years ago, if you'd told me I'd be presenting Grand Rounds today in Mass General Hospital's Ether Dome, I would have told you that you must be crazy. Absolutely crazy. Why would I be presenting Grand Rounds today? And the reason why I would say that is because I was a nephrologist in private practice for many years in beautiful Denver, Colorado. I was a fully vested partner in a large group. I was the medical director of 2 dialysis units and had 3 offices in the northern suburbs of Denver. I had 10 weeks of annual vacation and a 4-day work week. So yeah, why would I be here, right? Good question. So I would like to briefly describe a typical day of my practice in Denver. Nephrology practice is located in 3 different venues: the hospital, the dialysis unit, and the outpatient clinic. My days would start very early in the hospital ICU, seeing the sickest of the sick on dialysis. I would see follow-ups and new consults in the hospital, and then I would drive to my clinic seeing chronic kidney disease patients who some of them would end up on dialysis someday. Then I would go to the dialysis unit and round on dialysis patients. My typical day, I would be driving back and forth from these different locations, and I would learn how to think fast and move fast. And in the course of the day, I would be asked to stamp out small fires of disease, or I would have to address large tsunamis of life and death situations, and it was nonstop sometimes. I would have colleagues calling about mutual patients, and also I would get calls from patients and their families concerned about their kidney care. It was in this environment that I actually developed a passion for palliative care because I saw so much suffering in these locations. But I grew very frustrated because I could only keep them alive on dialysis and I could not palliate them. So I became burned out. And during this time, my dad also was diagnosed with stage 4 cancer. So I made the decision to leave practice and pursue a career in palliative care. And that's why I'm here today. So just short, quick story about that. So I am very proud to present the palliative approach to dialysis care, the shifting of the treatment paradigm for end-stage renal disease. These are my financial disclosures. They do not make me bad people. So I'd like to start off by describing the need for palliative care in the American end-stage renal disease population. Then I'll follow that by discussing barriers to the palliative approach to dialysis care in the outpatient setting. And then we'll end with some possible models of palliative care for ESRD patients. So I'll start with one of my patients in my dialysis clinics. He was a 62-year-old man with advanced kidney disease due to diabetes who was admitted to the hospital and found to have newly diagnosed cirrhosis. Like many of my patients with kidney disease, he crashed onto dialysis in the hospital and he was diagnosed with end-stage renal disease. We accepted him to our outpatient dialysis clinic with open arms. I met him. He had a tunneled catheter. he would develop severe hypotension on dialysis, which make dialysis, blood cleaning, and fluid removal very difficult. He had a very hard time adjusting to dialysis, and he told me he hated dialysis, and the only reason why he was doing it is because his family wanted him to. He said that his only hope was to receive a kidney liver transplant, and he worried that he would spend the rest of his life on dialysis. He would grow very frustrated because his low blood pressure would prevent us from removing significant fluid on dialysis, and he would refuse makeup sessions to catch up. This led to weekly paracentesis to remove volume from his abdomen. Over the coming months, he had multiple hospital admissions due to complications from cirrhosis. Because of his declining health, he was told by hepatology in one of his hospitalizations that he was no longer a candidate for transplant. When I saw him next, he was devastated. He was also suffering extreme fatigue, weight loss, decreased appetite, and severe peripheral neuropathy. I offered to refer him to palliative care outpatient, and he accepted, but he told me that he was not ready to die and he wanted to continue to be a full code. So my dialysis visits were very focused on disease metrics of care on dialysis. So I was very focused on, number one, ensuring that patients had enough blood cleaning of uremic toxins. This is what we call dialysis adequacy. Also removing enough fluid during dialysis. And this is ensured by a 3 times per week dialysis schedule on hemo, as well as each session lasting 3 to 4 hours. I was also very interested in making sure these patients had permanent access for dialysis, AV fistulas or grafts. If they had catheters, I aggressively would refer them to a surgeon for a fistula because these catheters are dangerous. They're associated with life-threatening infections. I was also treating all their other issues like anemia, malnutrition, bone disease, and ensuring they had a proper renal diet. But I left a lot of symptoms on the table because I just didn't have the time or the skill set to treat them. For instance, chronic pain is very common in the ESRD population. About 50% suffer from it. And of these, 80% rate their pain moderate to severe. Depression is extremely common. 40% suffer from depression, which has been found to be an independent risk factor for mortality in this population. If it wasn't for all these symptoms that I couldn't manage, there is also an equal amount of psychosocial issues. We do have social workers in our dialysis units. They're very overworked, and they deal with these issues plus advanced care planning. But many surveys have said that patients, dialysis patients, want their nephrologists to lead discussions regarding goals of care and advanced care planning, but I simply didn't have the time. So how many patients are living this life on dialysis? In 2016, the number of new cases of ESRD were approximately 125,000 patients, the majority of which were 65 years and older, defined as older age, or 75 years and older, defined as advanced age. The prevalence in ESRD in 2016 rose to 725,000 patients on dialysis. And of these, the prevalence was highest in the older and advanced age groups. The exact populations that suffer the most disease burden due to multiple comorbidities as well as frailty. So regarding mortality rate, the Medicare dialysis population has a mortality rate that's 10 times that of the general Medicare population. The 1-year mortality of an older age dialysis patient is approximately 30%. The 1-year mortality of an advanced age dialysis patient is approximately 40%. And studies have shown that the Medicare dialysis population has a higher mortality rate than those with cancer, diabetes, and cardiovascular disease in the Medicare population. So what are the risk factors for high mortality the first year after starting dialysis? Melissa Wachterman over the VA Boston published data from a longitudinal survey of Medicare beneficiaries over the age of 65. In it, she found that 55% of dialysis patients over the age of 65 died within 1 year of starting dialysis. What was very concerning was in patients 85 years and older on dialysis, 70% of them were dead 1 year after starting dialysis. After multivariate analysis, she found that the highest risk factors for one-year mortality in this cohort were dependence on activities of daily living, advanced age, 85 years or older, the presence of 4 or more comorbidities, and dialysis initiation as an inpatient. I thought this was very interesting data because we in palliative care see so many cancer patients. This is data out of Ontario, Canada, which was a mortality study comparing the newly diagnosed ESRD patients with the newly diagnosed cancer patients. And in it, it found that patients with ESRD had a lower survival probability than those with colorectal cancer, as well as breast and prostate cancer in women and men, respectively. What was also very interesting is that the patient that was over 70 years old on dialysis had a similar 10-year survival compared to as similar as patients with lung cancer and pancreatic cancer. So how are these patients spending their final month of life in the final month of life? Well, many of these patients, the elderly dialysis patients, are spending their end of life in the hospital, unfortunately. So Wong and colleagues in 2012 did a mortality study characterizing the end of life patterns of care in the hospital in the final month of life. This was compared to Medicare beneficiaries with cancer and heart failure. She found that the dialysis patient in the final month of life, 76% of them were hospitalized at the end of life. 50% of them were admitted to the ICU, and 30% of them had an intensive procedure like mechanical ventilation or CPR. What was very concerning was that 20% of these dialysis patients in the final month of life were referred to hospice, only 20%. And this was compared to 55% of cancer patients and 40% of heart failure patients. 6 years later, Wong again published mortality data, this time in a VA cohort, and she again showed that Medicare dialysis patients in the final month of life utilize high intensity patterns of end-of-life care. What was also interesting in this cohort is she analyzed advanced kidney disease patients who decided not to pursue dialysis in their final month, compared to decedents who received dialysis until the end of life. The patients that decided not to pursue dialysis were less likely to be hospitalized, less likely to have an intensive procedure or die in the hospital. What was also very interesting is that these patients that did not pursue dialysis had a higher likelihood of having inpatient palliative care consultation as well as being enrolled in hospice. It's worth noting, though, that even these patients who did not seek dialysis, over 50% of them still were admitted to the hospital. And this suggests that even though they transitioned to hospice, they first started out with aggressive care and decided not to dialyze. So the data has been very clear in multiple studies that ESRD patients are less likely to participate in advanced care planning. So Corella and colleagues analyzed a cohort of nursing home residents and found that the ESRD patients in the final month of life, or the final year of life, were less likely to have treatment-limiting directives or a documented healthcare proxy. And this was compared to residents who suffered from cancer, COPD, and dementia. So I hope with all this data that I presented that I think we could all agree that palliative care is very important in the ESRD population, particularly in the elderly, frail, with multiple comorbidities. Their prevalence is increasing through the years and will continue to do so. The mortality rate in these older populations is high. Many of them experience end of life in the hospital. They do not have advanced care planning, and many of them are not referred to hospice at the end of life. So considering that there's a high morbidity mortality in these older populations, it's very easy to see that the burdens of dialysis care frequently outweigh any benefits for them. And I would propose that if we offer a palliative approach to dialysis in patients in which we shift the focus and the emphasis to minimizing burdens of these very rigid dialysis schedules, like 3 times a week, and also shifting the focus away from diseased disease metrics of dialysis care, perhaps these patients will be better treated and more comfortable at the end of life with some dialysis. So what is the palliative approach to dialysis care? When the ESRD patient nears the end of life, the emphasis of dialysis care shifts to an increased focus on symptom control and goals of care to ensure quality of life and comfort. So instead of those metrics that I described earlier that I did on rounds, like getting fistulas in these patients, ensuring adequate dialysis with 3 times a week hemodialysis, and also aggressively treating anemia and hypertension and bone disease, that we actually shifted. We go into a patient-centered approach, where for some patients, a catheter would be acceptable for dialysis if they choose so, and they have less than a year prognosis. So they don't want surgery. Also, allowing a more relaxed schedule of dialysis, maybe once or twice a week only, just to palliate their uremic symptoms and volume overload, so that they have more time at home with family before the end of life. We'd also relax the treatment of anemia, bone disease, and just palliate these symptoms with medicines as needed, and also liberalize their diet for comfort, so we won't have to worry about so much about phosphorus or potassium. So this sounds like this may work in the dialysis patient population, at least in a small amount, but why is this not being done now? Well, there's actually 3 barriers that I want to discuss regarding this approach in the outpatient setting. This is not an exhaustive list, but I think these are the most important. The first one's a lack of comfort and adequate palliative care exposure during nephrology fellowship that leads to practitioners in nephrology being unprepared. Also fiscal barriers in how Medicare reimburses outpatient dialysis. And the last one would be the inability for concurrent reimbursement of ESRD and hospice Medicare benefits. So I would first like to start off that there's multiple reasons why nephrologists are not conducting serious illness conversations. I think this was best articulated by Drs. Mandel, Bernanke, and Block over at the Brigham when they had a review article published about the serious illness conversation in ESRD. In it, they described that the reasons for this might be because nephrologists don't have the time, they don't feel it's their responsibility, they don't want to upset their patients, they feel that there's too much prognostic uncertainty to have a good discussion, and they're also insecure with their communication skills. Personally, in my practice, I just didn't have enough time, I thought, and I also didn't have the training. I felt insecure in my skills. So an interesting cross-sectional online survey was conducted in 2013 of second-year renal fellows in U.S. fellowships, and 95% of them said they thought it was very important to have palliative care skills taught during their fellowship for their future dialysis patients. However, less than 50% of them said that they were taught how to assess and manage pain in dialysis patients. Less than 50% were taught how to determine when to refer to palliative care and hospice, or how to deal with a patient's request to stop dialysis. Less than 50% were taught how to conduct a family meeting. Of these U.S. renal fellows, 70% of them said that they performed over 10 renal biopsies and had direct supervision, and most had feedback. But unfortunately, the majority of renal fellows conducted very few family meetings, if any, and the few that actually did over 10 during their fellowship, less than 10% had direct supervision, and almost none of them had any feedback. In my nephrology fellowship at Vanderbilt, they didn't even have a division of palliative care at the time. I did not conduct one family meeting. I was not even told how to. It wasn't even mentioned to me as a possibility. Now my program director at Vanderbilt, she says that there is a division of palliative care. It's very, very well regarded. And these renal fellows there are now required to participate in a 2-week inpatient palliative care elective. So I think this is a step in the right direction. I just hope that more nephrology fellowships are incorporating palliative care training in their fellowships. So the next barrier deals with how Medicare pays outpatient dialysis. So a brief history lesson. In 1965, Medicare was passed to provide medical insurance to Americans 65 years and older. But it did not extend coverage to end-stage renal disease. Now, at the time, kidney failure was a fatal disease. Very few academic centers were offering dialysis. But as it became clear that dialysis was going to be a chronic therapy that was going to be available to Americans, policymakers were very concerned that insurance was going to be a barrier to receive dialysis for most Americans. This led to the Medicare ESRD benefit. In October 1972, the Democrat-controlled Congress passed the Social Security Amendment of 1972. President Richard Nixon signed it into law 1 week before the presidential election. This amendment extended coverage to all ESRD patients less than 65 years of age. So an 18-year-old could receive Medicare, as long as the patient had worked enough to qualify for Social Security. So this was actually enacted in 1973, and it was the first Medicare entitlement that actually extends coverage to a specific diagnosis, the first of its kind. At the time, in 1973, the ESRD population was only 55,000 patients. Most of them were young people who wanted to use dialysis to rehabilitate to return to work. In 1954, the first successful kidney transplant was performed at the Brigham and Women's Hospital, and the hope was that most of these patients would get a kidney transplant. Policymakers did not believe or dream that the prevalence would increase to what it is today, a population mostly being of elderly disabled patients who are unable to work, that are using dialysis to prolong life and not to rehabilitate. At the time, the policymakers did not believe that ESRD care would be so expensive to Medicare. In 1973, the average cost of dialysis was $20,000 per patient per year. In 2016, hemodialysis costs $90,000 per patient per year, and peritoneal dialysis was $76,000 per patient per year. 2016, the annual Medicare budget for ESRD costs was $35 billion, and this accounted for 7% of Medicare paid claims, even though the ESRD population represents less than 1% of the total Medicare population. So to address these high expenditures in the ESRD population, Medicare changed its reimbursement to facilities in 2011. It started with a prospective payment system called PPS, and what it did was that it lumped all the dialysis costs, the treatment, the drugs, the labs, into one payment per treatment to the facilities. And this bundle, if you will, was approximately $230 per treatment in 2017. It next started the Quality Incentive Program, or QIP, in 2012, where it actually established performance metrics on clinical outcome measures that were graded at the facility level. So payment was linked to performance, and actually a facility could be penalized reimbursements if they did not perform up to a specified level. And then in 2015, Medicare started a new payment model in which legal partnerships called ESRD Seamless Care Organizations, or ESCO'S, were created. These organizations were partnerships of dialysis companies and nephrologists who were expected to come up with new, innovative ways to treat their dialysis patients. They were also going to be financially responsible for their clinical outcomes. So these organizations could make money if they had good clinical outcomes and reduce hospitalizations. But they could also lose money if too many of their patients were being hospitalized. So considering that the hospitalizations represent about 40% of the ESRD costs for Medicare per year, these organizations could lose a lot of money. So the ESRD QIP, the Quality Incentive Program, is the first pay-for-performance program in Medicare history. I would look monthly at these clinical measures, and some of them are actually measures I already mentioned, like vascular access, as well as dialysis adequacy, how well we clean the blood. And let's say, for instance, your facility had a lot of catheters, then you would be negatively scored. If you had enough patients below what was considered adequate dialysis, you would be negatively scored. The other measures, such as patient surveys submitted from the facility, hospitalization rates, transfusions, hypercalcemia, were all measured. There are also safety and reporting parameters that would be factored into the total performance score. This score, at the facility level, if it was between 60 and 100, then Medicare reimburses 100% of the payments for all the Medicare patients. However, if it's less than 60, then there is a graded reduction in payment to a maximum penalty of 2%. So considering that Medicare is a primary insurer for 90% of ESRD patients, a facility could lose a significant amount of money if they're not performing well. I mention this because what if we had a facility that had a lot of palliative dialysis patients, and it was acceptable for a lot of them to have catheters and receive palliative dialysis, not the standard of care amount of dialysis? Well, you could see that these facilities would actually lose money, but they're actually doing the right thing. They're advocating for their patients, and those other patients that are not doing palliative dialysis, they're doing really well with them. But in Medicare's eyes, not so much. So what makes it even worse is that Medicare actually posts these scores online in a website called Dialysis Facility Compare. So patients and families could look online, compare scores between clinics, and conclude certain things. Well, this is based on a 5-star scoring system. So this is what I call Yelp for dialysis units, which is a good thing. Transparency is great. But the things, if you can imagine, some patients and families might say, wow, this dialysis unit has only 3 stars. They must have given terrible care. But in actuality, they just have a lot of dialysis patients that are getting palliative dialysis, and it's falsely bringing down their scores. So a facility could actually lose future business on the impression that they give substandard care. So this is an example on the right of my dialysis unit, actually, in Westminster. And my competitor is on the left, down the street. And my unit got 5 stars for clinical outcome measures compared to 3 stars to my competitor. My competitor had 5 stars on the patient experience surveys, but for some reason, my dialysis unit didn't publish my surveys of the patient. I don't know why. I need to call them. But I guarantee you they were really good. But basically, there's so many factors against a palliative approach to dialysis because the current payment model disincentivizes palliative dialysis. And if you have the juxtaposition of incentivized disease-focused metrics with individualized palliative patient-centered approach, this will create conflict between the dialysis management and the nephrologists because they have an interest in seeing their facility be successful financially, but they're also charged with advocating for the patient to do what's right medically for them. What also creates conflict would be that patients whose goals of care do not align with this incentivized disease-focused approach will be very unhappy. So what Medicare does is they put in all these performance metrics into one silo. They don't really care if patients' goals of care or poor prognosis would align more with palliative. They grade everybody the same. So Medicare could perhaps incentivize some palliative care metrics, or at the very least not penalize facilities who some patients want to receive palliative dialysis. Maybe we could lift some of this financial burden from the facilities, but until then, I don't think it's gonna happen because they literally cannot afford it. They wanna do the right thing for their patients, but they don't want their facility to possibly close down or have to lay off employees. Hard situation. So the third barrier is how Medicare pays for both hospice and dialysis. As you know, the hospice benefit covers care for the terminal illness if the prognosis is 6 months or less. Some people don't know, but actually, if a dialysis patient has a terminal condition which is not related to ESRD, they actually can receive both dialysis and hospice coverage by Medicare. So if a dialysis patient has, let's say, cancer that's not related to ESRD, If they choose to, they could receive dialysis and be admitted to hospice, and it will be covered. How about if the terminal diagnosis is ESRD or related to ESRD? Well, Medicare will only pay for hospice, not dialysis. And the issue with this is that if the dialysis patient wishes to continue dialysis, then the hospice agency would be financially responsible for all dialysis care. Well, earlier I mentioned that the cost of one hemodialysis treatment was $230. Well, the cost of routine hospice care per day is $150. So a hospice agency cannot afford to offer dialysis care to any patients that would wish for it. And this is very difficult because a patient has to abruptly withdraw from dialysis to receive hospice. Well, considering that after withdrawing from dialysis, an anuric ESRD patient has approximately 7 days or less to live, this does not give enough time for the patients or the families to prepare for death. They don't have enough time to say goodbyes and finish unsettled business. They don't have time to actually meet the hospice team so that they could develop some rapport beforehand. So this type of approach really is fear-driven. There's a lot of anxiety on the patients and families because they feel that they're going to be unsupported and suffer at the end of life. It's not surprising that many of these Medicare, the dialysis patients, the smallest share of Medicare spending for them goes to hospice care. If you look at the small sliver that's maroon on the top, represents hospice expenditure. This is not surprising considering the all or none approach to dialysis and hospice in this population. And it's also not surprising when you consider that many of these ESRD patients are not having serious illness conversations or advanced care planning early on in their disease course. So many of these patients end up in the hospital at the end of life, and they end up transitioning to hospice very late, if at all. So I would propose that if we had earlier palliative care referral, right away at the initiation of dialysis, then maybe we could have a smoother transition to hospice care that's not crisis-driven and in the hospital at the end of life. They could actually be at home and there could be somebody taking care of them, and they never have to worry about being in the hospital, but we need palliative care involved. So how can we overcome these barriers? Well, I think in the provider level, I think nephrologists and nephrology fellows should be better prepared with palliative care skills coming out of training. I think CMEs should be offered to practicing nephrologists to learn these communication skills. And I also think that we in palliative care need to reach out to our nephrology colleagues and offer our assistance, our education, help devise models of care for ESRD. I also believe that Medicare needs to change their reimbursement for dialysis so they're not penalizing dialysis facilities if patients choose a palliative care route. They should also incorporate palliative care measures into the ESRD QIP, and also perhaps incentivize peritoneal dialysis and reimburse for staff-assisted home dialysis. I'll mention a little bit about this shortly. Also, I believe that Medicare should allow joint ESRD and hospice benefit in those that are most at risk, so that they are supported if they want to do palliative dialysis if the terminal diagnosis is ESRD. And then perhaps ESCO'S could partner with palliative care providers to broaden the care for ESRD patients. So quickly, peritoneal dialysis is a modality performed at home. Less than 10% of US dialysis patients perform peritoneal dialysis, which is the opposite of what we see globally. Most countries around the world offer most commonly peritoneal dialysis, and very few actually do chemo. It's less costly, as I mentioned, compared to hemodialysis, and it has less symptom burden compared to the hemodialysis. And why? Because it's a very slow, gentle, daily form of dialysis at home, which would be a perfect match for these elderly patients, like with heart failure, for instance, who can't tolerate hemo. And it could also fit into a very good palliative model. In Canada and European countries, they actually cover for staff-assisted nursing care for patients who need help doing peritoneal at home. We don't have that at the US, but if we did, I think it would actually fit into a really nice model of, let's say, home-based palliative care or home-based hospice, and where the visiting nurses are going to be there anyway, and then maybe they could help them with their palliative dialysis at the end of life. So I mentioned ESCO'S, and I think the ESCO'S can pair up with the palliative care providers, and that'd be great, because then we could offer these enhanced models of care that Medicare wants. But I think we have to be very careful at the same time to avoid conflicts of interest, because, as I mentioned, these organizations could actually financially profit if these patients are not being hospitalized. And if we give and offer a conservative approach to their care and dialysis is not offered, then they'll have less hospitalizations. So I believe to avoid conflicts of interest, perhaps making sure that at least the palliative care providers do not have a financial stake in the organization so that they could give unbiased information and advice. I think this is going to be a very tricky way to navigate this future. And I think Medicare also has to be watching and have some regulation to make sure that we protect the patients. So this is a possible model, I think, that could work. At dialysis initiation, we have a palliative care team screen and perform goals of care and advanced care planning. And if the patients choose to have life prolongation, rehab, they want aggressive care, then we'll go on with the usual disease-focused model of care I've described. But for those patients who are most at risk, they should have regular palliative care follow-up with one of our teams to have symptom management advice as well as ongoing goals of care. If the goals of care shift at some point during their dialysis journey, then at that point is when we switch the approach to a palliative model for a time-limited trial. And if the patient hasn't had a fistula placed, then they keep the catheter. We could relax their dialysis schedules. We could palliate anemia and bone disease, liberalize the diet. And then at some point, with the palliative care team, patient, family, we could plan a hospice transition that's outside of the hospital and they're comfortable at home with a plan of withdrawing from dialysis. I think that this could work, but again, I think some of the barriers from the financial standpoint need to be worked out. This could also be started at dialysis initiation. So if patients just choose this type of approach, they could start off with it and go on to the end of life. Also, advanced kidney disease patients like stage 5 CKD, if they decline dialysis, that's fine. We could do initial palliative care screening, but we also have to realize some of these patients actually might be doing well for many months to years. And it's only when they start feeling uremic, then we could transition them to hospice. I actually had several patients like this, like octogenarians that didn't want dialysis, and the creatinines were like 5. And I was like, wow, you're healthy. You don't need dialysis. And they were so happy, but they were like that for years, So I think we could have follow-up with these patients. It just might take a little bit of time for them. So let's return to our patient case. Mr. RS went to outpatient palliative care. He wasn't interested. He wanted to live. He didn't really see the big picture of how it could be beneficial. Unfortunately, he was readmitted to the hospital for GI bleed. And during this hospitalization, he said, he was done. He didn't want to come back to the hospital. He changed his code status to DNR. The inpatient palliative care service saw him, and patient decided to transfer to home hospice. His terminal diagnosis under hospice care was cirrhosis. And then I was told that, he still wanted some hemodialysis, maybe like 2 times per week for a couple weeks, because he wanted to make it to Thanksgiving. And his last wish was to share Thanksgiving dinner with his family and watch football, which he did. So we did it. We made sure his dialysis was, 2 hours, twice a week. We just got enough fluid. And after Thanksgiving week, he withdrew from dialysis and he died peacefully at home 5 days later. This was only one patient that I had that did this. Many others weren't so fortunate. I would arrive to the dialysis unit one day and they said, well, Mr. Smith's not here. And I said, well, what happened? He died in the hospital. And I never had any follow-up. You know, I kind of saw it coming. They're elderly, there's risk factors, and it just would be like that. So I hope that palliative care becomes a priority in the ESRD population. I hope that the stakeholders in ESRD care will have the courage to initiate bold change. And I hope these stakeholders also reach out to palliative care. I hope that we offer our assistance as well for the most at-risk patients. And I hope these patients and families actually accept and benefit from this care so that they're comfortable and supported towards the end of life. So memento mori is translated to remember you'll die. And I know this sounds like kind of pessimistic, but actually all my dialysis patients, my palliative care patients, and my father, who passed away last November, have all taught me to embrace life, to live it to the fullest, with the time remaining, because you just never know when you could die. And that's one of the lessons I will leave here with. I want to thank my fellowship classmates for helping me so much when my dad was in hospice and when he died. I'm so indebted to you, and I look so forward to seeing your many successes. I'll be your biggest fan. To my program directors, Kathleen and Jane, thanks for accepting me, and I hope I've given to this program as much as it's given to me. To all my attendings at both hospitals, thanks for teaching this old dog new tricks. This old dog with long hair and too many tattoos. And to all the interdisciplinarian staff at both hospitals, the social workers, the chaplains, the nurse practitioners, you all taught me so much. Thank you so much. And to my mentor, Josh Lakin, and Kidney Pal, Ricky and Kate, I look so forward to seeing you lead the revolution of palliative care and nephrology. I expect a lot of articles being published out of the Brigham with this, and I look forward to collaborating with you in the future. And most importantly, I have to thank my wife. She signed my permission slip to even be here in Boston. So if it wasn't for her support, I couldn't have done it. And then, of course, lastly is my father, who he taught me many lessons over the last year, and I'll never forget them. So I hope you enjoyed my presentation. I hope it was fruitful, and thank you very much.
Are there any questions here?
Thank you so much. It was wonderful. You know, I hold in my memory many of my patients that are end-stage renal disease and dialysis, and the challenges in the hospital where it appears that our discussions are about withdrawing care. And in many of these situations, there's a religious component, as well as minorities, people of color who, you know, don't have necessarily a strong background of good care, or access to good care. And I'm wondering if you have any thoughts about those intersections.
Yeah, I mean, I've seen that, you know, a lot of ESRD patients, particularly religious or those from minority backgrounds, they struggle about the withdrawal concept. And I think there's many reasons for that. One thing that I did as a nephrologist try to convey, and I think it's the nephrologist's job, not the palliative care, is to describe how the end of life could be off dialysis, because there's a lot of fear. I know Juliet and I in clinic the other week had a patient and family just like this. And you have to really express to them that we're going to be there for you. You will have hospice. Try to explain the concept. but also the nephrologist has to also explain that when you become uremic, we could palliate you with medicines, but when you start getting very uremic, you just go to sleep. You know, you go into a nice coma, and most of us would prefer to die in our sleep peacefully. So when I mentioned and described it that way, they tended to kind of relax a little bit and realize that, you know, the end of life might not be so scary after withdrawing from dialysis. But again, they want to hear from the nephrologist, because that's the person they've been seeing. Just like the oncologist with chemotherapy, the nephrologist is the one that's been seeing them for years, and I think they would feel more comfortable hearing that from that person, because they're the expert in the procedure. So that's kind of my experience with that. So great question.
I have a comment and a question. First of all, thank you. That was fabulous and a really great way to sort of synthesize so much information for us. My comment is that maybe there is change, generational change coming, in that we used to have 0, maybe 1 nephrologist apply. You are our first nephrology fellow here. We have another one coming next year. When I looked at the applications last year, I think we had, out of 150 applications, maybe 8 were from nephrology fellows. So I feel like there must be that feeling coming, and I'm hoping that they will be the change that's needed. And so that brings my question about, are you aware of groups either in palliative care or in nephrology that are advocating for these changes that you put forward?
Yeah, I've heard that in academia there are some programs. I've heard in Seattle and in West Virginia, the institutions there are some. The University of Pittsburgh actually is collaborating with DCI, which is a dialysis company based out of Nashville, with an ESCO, and they actually presented data at HPM in March that showed that they had a pilot study of something that I described regarding the transition to hospice in a pilot study. So there is interest, and this is a dialysis ESCO with academia, and they also had a hospice agency also involved. So I think it's there. I think we just need to have more of it, and also address the barriers, particularly financial. Yeah.
I want to open it up for any questions at Dana-Farber or at Care Dimensions. All right. Well, thank you so much, Phil. This is really fantastic.